All right, if you've been following me for a while on Instagram, you've seen me debunking a fallacy that is common amongst personal trainers, potentially physical therapists, strength and conditioning coaches in the strength and conditioning industry. And this has to do with anterior pelvic tilt and the incidence of back pain, which sometimes in some research has been shown to have a correlation, but we don't yet have the direct line of causation from one or the other. So today I'm going to go through a few research articles that are out there on musculoskeletal disorders and, more importantly, low back pain and an anterior pelvic tilt. And how can we draw the line between the two, or can we draw the line between the two? I want to start off with a bit of a disclosure. I'm a certified strength and conditioning specialist. I am not a physical therapist and I am not a doctor. So I don't manage athletes with chronic pain. Now, that's not to say that we're not going to encounter pain at all in our strength and conditioning journey. We should expect to encounter some pain. But when things become chronic, we need to send someone to a specialist, i.e., a physical therapist or a doctor, because they're more well versed in diagnostic tools than strength and conditioning coaches are, or personal trainers. So they'll be able to offer you more of a why behind your pain than I will. But I'm going to cover this as a strength and conditioning coach and how I would interpret it as a strength and conditioning coach, and how I feed this information to my clients to educate them and give them more autonomy. Now, that's not to say that the people who are trying to draw a line of causation are wrong. I think as humans, we are inherently curious and also inherently anxious. And so having that why sometimes takes the autonomy away from us and makes us think that there's some underlying aspect that might be causing this pain. And there isn't always an answer, but we're always looking for an answer as human beings, and that's okay. That helps to ease those anxieties that we have around pain. More so, is this going to last forever? Is there something that I did to create this pain? Is it reversible? Right? These are all valid anxieties that we can have around pain, but we also need to understand that there is a level of autonomy that we can take out of this and not dive deep into the weeds, into the nuances of things that we don't understand. And we don't want to start drawing conclusions or causation lines between two things that don't necessarily have causation. Like I said, they might correlate. Sometimes the data says, yes, people who are in an anterior pelvic tilt or have severe lumbar lordosis are in pain. There's a correlation there, but that doesn't necessarily mean that one causes the other. And I'll get to this more specifically in one of the best articles I've read to date on lumbopelvic pain and lumbopelvic position. So while this is a complex image, I think it's great to start here because we can define some terms. When we talk about lumbopelvic position, we're essentially talking about body biomechanics. And now in the center of this picture, you have pain, you have quality of life, and you have all of these other variables surrounding it that feed into each other and back into pain, back into quality of life. So this is a very complex image, but what you can take out of it is that it's not just biomechanical factors that affect pain. It's not just psychological factors that affect pain. There are a lot of other variables that can feed into our perception of pain and what that does to our quality of life. So this is an image that's been rolling around the internet, and while it's very confusing, I think it speaks volumes in the direction that research can go in order to find a solution for or an answer for that. Why do people suffer low back pain so chronically or just pain in general. And that can start to ease some of our anxieties. But we also want to make sure that we're taking most research with a grain of salt, because every research study has its limitations. I've been there. I've written a thesis. I knew the limitations that were behind my thesis. And a lot of research gets published despite having major limitations, because it's important for us to have those answers and to realize what happened in one research article we can build on and continue to chase that answer that we're looking for, albeit it may never be perfect. Okay, so let's start with an article that was sent to me by a fellow strength and conditioning coach supporting why biomechanics cause biomechanics such as lumbar lordosis or an extreme anterior pelvic tilt. So, okay, going back to defining terms. Your pelvis looks much like this. When we're in an anterior pelvic tilt, the front of our pelvis is going to dip down, the back of our pelvis is dipping up. And what this causes is a little bit of an angle at our lumbar spine. A posterior tilt would be the opposite, or tucking our tailbone underneath us, pulling that spine and elongating it, lessening the lordosis of the spine. So this article was sent to me in support of lumbar lordosis, or an anterior pelvic tilt, being the cause of low back pain, especially in those that sit for an extended period of time. And while it was a very well thought out article, I don't want to take anything away from the researchers who did this. There are some limitations within this research that don't necessarily draw that causative line between lumbar lordosis or an anterior pelvic tilt and low back pain. So this had about 40, they ended up having about 41 participants. They collected, data from 61, but only ended up using 41 of them. And one of the exclusion criteria, which really kind of piqued my interest, was that they utilized data from the NPRS, which is the numeric pain rating scale. And that just is essentially a scale from 0 to 10 where you rate your pain intensity. And then they also utilize data from the Oswestry Disability Index, which is an index that classifies the quality of life or the change in your quality of life due to the back pain. And it's ranked from 0 to 5, and usually means from no disability to, severe disability. So they utilize these two scales in order to kind of separate the data, or separate the participants into two different groups. Well, they didn't use this to separate them into two different groups, but they use this to kind of correlate whether or not that pelvic position or biomechanics feed into pain and disability, right? So they excluded those who scored a 2 or less on the NPRS scale, which means they were not including anyone who had essentially low levels to no back pain, which is fine, because then we're going to go along and look, with these two groups that have back pain, we've kind of normalized that they both have back pain. Does the group with anterior pelvic tilt have more than the group with a normal pelvis or normal, I think they used degrees, and they limited inclusion of those who scored less than 10 on the Oswestry Disability Index. So right off the bat, they've excluded people who have less or no back pain and those people who had no disability. Like I said, I think they're trying to draw a level playing field amongst the two groups that they split them up into in order to try to correlate those two things. But completely excluding those without back pain can be an issue, because what if those people without back pain and without disability also had severe degrees of anterior pelvic tilt. We're kind of cutting out an entire population in order to draw a causative line when we really can't, because there are those people who have anterior pelvic tilts and don't experience back pain. So a couple limitations on this article. And then when I scroll down, we talk about the significant data, statistically significant. Now, if you think back to statistics, if you've taken statistics, we apply a number called the p-value to the data that we've collected to determine whether or not it's statistically significant. Is this happening according to chance, or is this happening because there is probably a causative or a correlative relationship between the two? Now, if you remember back, it's a little p, right? We want a little p-value of less than 0.05 in order to determine things as statistically significant. And in these results, they talk about a few of the data points being statistically significant, while most of them were not statistically significant. So to make this easier, so that we're not, reading through 1,000 words, they give us a nice little table, which is fantastic. That's a fantastic research practice. Make this a little bit easier for people to comprehend by putting data in a table. So my hope with this video is that I can teach some of you how to read research a little bit more in depth, so that we can make these statements, or maybe not make statements that aren't necessarily true or aren't necessarily probable in our community. So you'll see there's no statistical significance in the difference between those with a pelvic tilt imbalance and those without a pelvic tilt imbalance, right? P-values are massive. There's a significant p-value in obviously the pelvic tilt imbalance. One without a pelvic tilt imbalance is going to be 0, right? So hopefully those with a pelvic tilt imbalance will be statistically significantly different. And then in terms of the ODI and the NPRS scores, which is something we were more keenly trying to keep our eyes on, is that the ODI score is statistically significant between the two. And remember, what the ODI score was that disability index. So those scoring, I think they shifted this into a percentage. So these numbers aren't necessarily going to correlate straight to that Oswestry disability index. But you can see that there's a statistical significance between those with a pelvic tilt imbalance and disability and those without the pelvic tilt imbalance. But there is still some disability without a pelvic tilt imbalance. And then the rest of the numbers down here, where we talk about range of motion, there's a few statistically significant. But if we're really looking at what we want to know about, is the cause of your pain from a pelvic tilt imbalance, we can't say with certainty. We can't say with very much confidence that those with a pelvic tilt imbalance experience higher pain scores than those without. So while there was some statistically significant data, there is no data that is telling us that your pelvic tilt draws a line of causation to your back pain. So those are my major limitations with this article, and I'll attach the URL code to these so that you have access to them and can read them if you so please. And I'm open to anyone who has any other interpretation of this. I love to chat about these things. So, but I'm pretty confident that this article specifically does not confirm that long-term sitting causes an anterior pelvic tilt, which causes your low back pain. All right, this is the other article that I found. It is a systematic review as well as a meta-analysis. And what this does is takes a lot of the other research out there on these topics and kind of condenses it into the data that we're looking to pull out of that. So instead of drawing causative or correlative lines in one data set, this takes multiple data sets and tries to average them together and will essentially give us the average of all of those data sets in order to draw a conclusion. Now, this is a very, very long and complicated research article, and at some point I plan to bring Rachel, my wife, who is going to be defending her dissertation for her PhD and is much better at reading the statistics themselves, or the reasoning behind the statistics, and explaining this better than I am. But there are a few things that we can take out of this right away without being professionals at reading research. So the reason this research is so vast is it covers things like range of motion, proprioception, velocity. The other great thing about this is they do quality assessments on all of the articles that they use, and they provide some of that data so that they're being very open with their limitations right off the bat. And so scrolling down, here's our quality assessment. I just highlighted some of the poor scores in red and some of the better scores in green, just so you have an idea. Assessors were not blinded as to which groups the subjects were in, which can typically be sometimes an issue because, those providers or those assessors could be using words that are going to, not saying that they are, but they could be using words that are going to dictate the outcomes. So, for example, if you've heard that anterior pelvic tilt causes low back pain, and you have a little bit of low back pain, and you look in the mirror and you see an anterior pelvic tilt, well, you might think that that is the cause because someone who is more knowledgeable than you and, more knowledgeable in that specific topic has made a statement that it potentially could or could not be true, but because they've drawn those lines in your head, you can also draw that line. So that is potentially an issue with a lot of these. None of the assessors in all of the articles that this particular research group used were blinded, which means they knew which group the subjects were in, and they might have put their own biases into the researchees' heads, which could cause certain outcomes rather than being completely random. But beyond that, they studied speed and acceleration, like they studied everything. So this particular figure here, and what I like to do is, for people to keep it as simple as they can, try to read these figures. Now, obviously, that requires you understanding what all of these numbers mean, but essentially they took all of these studies or subgroups and they compared those with in the low back pain group to the control group, and they've given us a weight of each of these articles on what this average total outcome is. But you can see with studies comparing lordosis and low back pain versus non-low back pain groups, there isn't a statistical difference, right? That standard mean sits right at 0. We cannot draw a conclusion that lordosis causes low back pain. Next one is flexion ROM, which we do know that obviously different biomechanical positions can bias or take away from certain positions we can access. That is not the question or the argument we're trying to make right now. But the one big thing that I took away from this article that was kind of brought up several times is, what came first, the chicken or the egg? Oh, and again, here's the small p for that lordosis with low back pain versus the control group. the p-value is way too high for us to be confident that we can draw conclusions from all of this data. So that's not saying that low back pain isn't caused by lumbar lordosis or an anterior pelvic tilt. It's just saying that this data that we have is not statistically significant enough for us to be able to draw a causative line. And that's where the question, the chicken or the egg, comes in. So are these deficits, such as reduced proprioception, reduced ROM, speed of movement, a result or a cause of low back pain? Does the low back pain come first and affect the position of our pelvis? Because we know, based on this article, that people with low back pain tend to choose one of the extreme pelvic tilt positions in order to find comfort. Or did a pelvic tilt cause the low back pain? We're unsure. So what this article is saying is that there is a lot more research to be done, and there are massive key questions that we have surrounding this. But right now, we cannot say that sitting and an anterior pelvic tilt is probably the cause of low back pain, because we don't know. The research doesn't conclude that. None of it concludes that.